Hello and welcome. I'm Saad Dinno, pharmacist and co-owner of Acton Pharmacy, Keys Drug in Newton, and West Concord Pharmacy. I would like to welcome everyone back to our show, A Healthier You. Our goal is to discuss relevant health topics and provide information to you, our viewers, that will guide you to a healthier lifestyle. Today's topic is Alzheimer's disease. An estimated 5.7 million adults are living with Alzheimer's today in the United States. So I'm pleased to welcome Dr. Brent Forrester, who is an expert on the disease. Dr. Forrester is chief of McLean's Hospital's Division of Geriatric Psychiatry, and he's an assistant professor of psychiatry at Harvard Medical School. His work centers heavily on the behavioral complications associated with Alzheimer's and the stress these complications place on caregivers. As director of McLean's Geriatric Psychiatry Research Program, he also investigates the causes of several mental health conditions, such as depression and bipolar disorders, that so affect the lives of his patients and their families. We have invited Dr. Forrester here today to better understand Alzheimer's, its symptoms and treatments. Dr. Forrester, thank you so much for being here today. It's an honor and privilege to have you joining us on our show. Can you please just discuss how you got into medical school? You know, why medicine, and why specifically geriatric care, and
Sure.
and also, you know, be even more specific than that, Alzheimer's disease, please. Welcome to our show.
Thank you so much for inviting me here today.
My pleasure.
I appreciate it. So I actually came from a long family history of physicians.
Okay.
Both my grandfathers were one was a psychiatrist and a neurologist,
Okay.
and one was a cardiologist. My dad passed along the psychiatry gene to me, although I did try other pursuits
Okay.
in college and eventually wound up in medical school.
Awesome.
While I was in medical school, actually, I think the area of medicine I was most intrigued with was internal medicine, neurology, and then probably psychiatry as the third thing. And one of the main reasons I wound up in geriatric psychiatry is it really brings all three specialties together.
Yeah.
When you're treating older adults with mood and emotional problems who have changes in their brain that are happening with aging or disease, and the importance, as you mentioned in your introduction, of working with families, that's really what was most appealing to me. I also was the person in the family who used to like to hang out with the older relatives and hear about their stories from when they were growing up
Okay.
many, many years ago, and have been fascinated when I've had the opportunity to do home visits to talk to people, see their environments, and see the pictures of what they looked like when they were younger, which has always been fascinating. So that's how I wound up in geriatric psychiatry.
Awesome. Thank you so much. Let's hone in on Alzheimer's disease,
Yep.
and that's our discussion today. What do we know currently about the causes of Alzheimer's, if we know?
Yeah, so I think the way I look at that question is, what are the risk factors for developing Alzheimer's disease? Alzheimer's disease, as you mentioned already, affects 5.7 million Americans in the United States today. One of the tragedies, frankly, is that only half of those people are diagnosed.
I see.
And of the half that are diagnosed, they're not diagnosed until they're already in the moderate stage of the illness. They've probably been having symptoms for years before it comes to anyone's attention. We'll talk more about why that is.
Sure.
But when I think about why people develop Alzheimer's disease, I think about the risk factors. And the number one risk factor is age. And the reason why we're really in an epidemic of Alzheimer's disease is because the first baby boomer turned 65 in the year 2011. And over the next 30 years, we expect that number to triple to be about 15 million Americans with Alzheimer's disease.
Wow.
Just because we're living longer.
Okay.
Not everyone who lives to be 85 will develop Alzheimer's disease, but about 40% or 30% of people over the age of 85 today have Alzheimer's disease, and the older we get, the more likely we are to have the symptoms. So that's number one. The number two risk factor is genetics.
Okay.
Now, there are certain genes that are extraordinarily rare that cause Alzheimer's disease uniformly in family members who are at risk. So they are inherited similar to Huntington's disease. If your parent has a gene, you have a 50% chance of getting it yourself. And if you get the gene, you get Alzheimer's disease. Now, these are rare genes. There are three of them that are well known and well described. and they occur in small numbers of families around the world. The most famous of which is probably the Colombian cohort in South America.
Really?
That group of 5,000 families
Yep.
has a gene that gets passed down through the generations. And if you get the gene, you get symptoms of the illness in your 30s and 40s, if not even younger. And there's
Wow.
a lot of research going on with that family. There was a great story on 60 Minutes
saw
about
that,
this about a
yes.
year ago.
Yeah.
But the most common gene is a risk factor gene called the ApoE4 allele.
Okay.
This gene, if you inherit 2 copies of the 4, not the 2 or the 3, but the 4 from each parent, your risk is probably doubled compared to that of the general population. But the problem with it in terms of routine clinical practice is that if you have the gene, it doesn't mean you're going to get the disease.
I see.
And if you don't have the gene, it doesn't mean you won't get the disease. So we don't use it routinely right now, today, in 2018, but we do use it in research studies to learn more about who may or may not benefit from certain new experimental medications.
Okay.
The other risk factors for Alzheimer's disease are many of the same risk factors that people with heart disease and stroke have. So problems like high blood pressure, high cholesterol, diabetes, those are all obesity, sedentary lifestyle, smoking, all of those risk factors that cause heart disease and stroke are also associated with the increased risk of Alzheimer's disease. And if you think about it, that means there's a lot that we can do to prevent or delay the onset of symptoms of Alzheimer's disease. I'll just mention one more risk factor
Sure,
because it's
please.
up my alley in psychiatry.
Absolutely.
And that's depression.
Okay.
If you have a lifelong history of depression with prior episodes of depression,
Okay.
your risk for Alzheimer's disease goes up regardless of other medical factors or other genetic risk factors. Independent to all of that, it increases your risk of Alzheimer's disease.
That's interesting.
We don't know why. We have a lot of theories, biological theories related to the recurrence of stress and what that does to the brain.
Okay.
But we do know that recurrent depression is a risk independent for Alzheimer's disease.
Thank you so much. That's a great segue into my next question, which is, most of us know loved ones who are getting older and maybe worried about whether they are developing Alzheimer's. And, those individuals that are in our families, how early do people start showing symptoms of the disease? I know we just mentioned these Colombian cohorts that are in the 30s, but what do you typically see in your practice?
So much more common than that would be people who are, entering into their midlife. And by the time you reach your 50s, even mid-40s to 50s, you start noticing that you're not quite as quick in coming up with the right words.
Right.
Or you might have misplaced the keys around the house, and you start to worry. And you especially worry, I think, if you've had a family history of this, and you wonder, is this now happening to me too? Okay. So there are some memory lapses that occur as we start to develop into our 50s or so. What happens as well, though, with people who are destined to develop the syndrome we call dementia, which is not just the memory loss, but also affecting their day-to-day ability to function, is that they're having trouble with things like decision-making and planning. They're having trouble with remembering even familiar names and people, much more significant than that. The problem is it's a fine line. Mm-hmm. And so what we really don't have, and what we need, is we need a very easily identifiable and relatively inexpensive biological marker. So in addition to the cognitive tests that we'll talk more about that we would do in our evaluation process, we need a test, a blood test, or some simple test that can say, well, this person has the disease in their brain, and that these memory lapses are related to the disease in their brain as opposed to anxiety or another medical factor. Again, we can talk more about that.
Sure. Thank you so much. Let's say I'm concerned that my father, for example, is forgetting his keys or glasses all of a sudden. Last week he was okay. This week seems a little off, if I may use that terminology. What does that suggest? Should I be concerned all of a sudden? So,
if there's an all of a sudden change in someone's memory that's occurred over days or a week, like you were just describing, that requires a good medical evaluation. And that's where your primary care physician is the best go-to person, because more often than not, even if there is underlying signs of Alzheimer's disease not yet diagnosed, which could be the case, there may be a medical condition such as an infection, a urine infection, pneumonia, Diabetes could be out of control. There could be new medications playing a role. There could be sleep deprivation. There could be any number of medical factors contributing to an all of a sudden decline in memory, this sort of falling off the cliff phenomenon. We call a syndrome of acute confusion delirium. Delirium refers to a syndrome that comes on quickly, is caused by a medical problem, and the cardinal symptoms are impaired attention. So it looks like their memory's not great, but really the problem is they can't pay attention to anything. If you have them repeat a series of numbers forward and backwards, they can't pay attention to do a simple 5 forward, 3 backwards series of numbers. That's different than dementia. Dementia, Alzheimer's type dementia, progresses really gradually over many, many years. And oftentimes when you ask families, when did you first notice that mom or dad or your spouse were having a hard time? And often they can't pinpoint the time when they were starting to have difficulty with their memory. Different than the story that you just described where it was an all of a sudden change.
And could it be a stroke? Could a stroke symptom?
Stroke could be another possible problem. You could imagine almost any medical problem in an older person whose brain is vulnerable to developing a confusional state or a delirium. We see this, by the way, a lot in people who are older who have surgery. They undergo anesthesia, they're in a lot of pain, so they go on pain medications, and the combination of both causes this confusional state that can last for days or even weeks or longer.
I see. And I think you hit on this. My next question is, what are some key differences among forgetfulness, dementia, and Alzheimer's, and maybe delirium as you described?
So let me describe the terms in a simple way, which I think would be helpful.
Thank you.
So there are 2 conditions that we talk about in our diagnostic system for memory loss. One is a condition we call mild cognitive impairment, or MCI. Mild cognitive impairment refers to people who are having memory loss, but they're functioning fine in their day-to-day life. And if it's the Alzheimer's type of memory loss, and by Alzheimer's type I mean it's caused by the brain pathology that Dr. Alzheimer saw in 1906 when he investigated in his first patient, and he found these sticky amyloid protein plaques in the brain and this other type of protein called tau, made up of tangles. But if it's the Alzheimer's type of mild cognitive impairment, the memory loss is inability to learn new information. So if I gave you 3 words to remember, and you registered them in your brain and you told me what they were, say baseball, table, and red, and then 5 minutes later after I distracted you with other things and asked you again, and you couldn't come up with the names, even if I gave you reminders and hints and cues, that's the type of memory loss people with Alzheimer's have. It's an inability to recall new information. They never stored it in the brain in the first place, so they can't get it out even with reminders. So when you have memory loss, but you're functioning fine in your daily life, meaning you're driving, you're paying your bills, you might even still be working, that is MCI, or mild cognitive impairment. When it becomes dementia, the memory loss is also associated with a change in day-to-day functioning. And that could involve things like not being able to dress oneself, or not being able to pay their bills, or maybe making bad decisions about finances, or not being able to function at work, etc. So when you combine a cognitive problem like memory loss with a functional problem in your daily life, that's dementia. Alzheimer's is one type of dementia.
I see.
Just like a Chevy is one type of car. But if you think about dementia as being a circle, 100% being the pie chart, Alzheimer's type dementia probably represents 2/3 of that pie.
Wow,
So it is the most common. So when we talk about dementia and Alzheimer's, we often use the 2 interchangeably. But it's important for the audience and for you all to know that Alzheimer's is one form of dementia. There are probably 50 or 60 other types, 3 or 4 being very common, but Alzheimer's being the most common.
Thank you so much. Is there an advantage to getting an early diagnosis of Alzheimer's, or does that even exist?
This is a very good question, and I get this all the time. If we have no cure today, why bother knowing? Right? That's the question. What's the point?
Fair enough.
And unfortunately, a lot of my colleagues in primary care, not all, but some, feel that's the case. So they don't look for it. Or they're concerned that if they do find a problem, they're not equipped with the tools or the know-how on how to manage it in the first place. So there are many reasons why the diagnosis gets delayed. There's minimizing the symptoms on the part of the person with the problem, but also the family. The person with the problem may not even know there's an issue. The family may not want to deal with the fact that there's an issue. But here are the reasons why knowing is important.
Sure.
Number one, the person with the problem, we need to figure out what it is. It could be a treatable medical problem like a vitamin deficiency or a thyroid problem, or depression that is otherwise treatable. So we need to find what's treatable first.
Okay.
Once we establish a diagnosis and we're pretty sure this is what's going on, then it's important that we provide the person with guidance about what may happen down the road and their family.
Okay.
How are we going to keep this person engaged and busy in their life today, improve their quality of life as much as we can? My view on Alzheimer's disease is not to think about what we can't do because you've got this horrible disease, but what we can do.
Of course.
And I don't think most physicians share that perspective.
Okay.
But having done this for 20 years, I can tell you that perspective makes a world of difference,
Absolutely.
both for the patients and their families. So early diagnosis can also help with financial planning and thinking about what may come down the road.
Sure.
And then in terms of treatment, which we can get into in more detail,
Yep,
there
that's
are
fine.
treatments on the market that can help slow decline for a period of time. The final thing I will say is nowadays, there are dozens of opportunities for patients to get involved in research.
Yep.
And the earlier the diagnosis, the earlier the symptoms, the milder the symptoms, the more likely it is that these experimental therapies will actually work.
Okay.
And we'll talk more about research, but it's going to be for the
Yes.
very mildest forms where the research has the most promise.
I guess my question just was, like for example, concussion testing.
Yeah.
You could get a baseline. For our audience, is there such a thing for Alzheimer's disease?
Absolutely. So
Okay.
the way we do cognitive testing is a series of rating instruments that assess the multiple domains of cognition.
Okay.
Attention, memory, organization and planning we call executive functioning.
Okay.
I talked about language, our ability to express ourselves or
Yep.
to understand the spoken word.
Okay.
Visuospatial skills, like can you draw a clock? Can you put the hands at 10 minutes after 11 and draw the hands correctly? So there are all sorts of cognitive tests that we can do. Today, the most widely used one, or the one that most of us in clinical practice are using as a screen, is called the Moca,
Okay.
the Montreal Cognitive Assessment, MOCA. It's non-proprietary. You can download it off the internet and take a look at it.
I see.
Although
Okay.
if your doctor was going to use it, you might cheat and practice. They do have many different versions of it.
Okay.
So that's one screening test that's widely used.
Yep.
But if it's confusing as to what the problem may be, if you say the Moca test, the score is at a 30, so you get a 24.
Right,
That's
right.
on the cusp of normal.
Okay.
You want to do more investigation.
Okay.
So you would do a neuropsychological exam with a neuropsychologist, somebody who's trained to do cognitive testing. Similar to a neuropsychologist can test kids with ADD.
Sure.
They can test kids with autism and learning disabilities, and they test older adults with cognitive problems, and they test people with concussion too. But that establishes that baseline you were talking about.
Correct.
And once you have a baseline, even if there is a problem, you can track people over time to see what happens. And often I find that that one slice in time is much less helpful to me as a clinician than what you look like 6 months from now, 2 years from now, 3 years from now. Those changes over time predict to me what may happen down the road.
Thank you so much. What are you mentioned treatments, and as a pharmacist, I know there's a lot of medications on the market. Currently that have been over the past several years. So what's currently available for Alzheimer's?
Yep.
If you may discuss that with our audience, and how effective are they?
So the treatments that are currently on the market basically are medications that alter brain chemistry.
Okay.
They do not remove the amyloid plaque or the tau tangles that cause the disease.
Okay.
They just treat some of the chemical problems that occur as a result of the underlying disease. So they are what we call symptomatic therapies. And the symptoms they try to improve are memory
Okay.
and other aspects of cognition that we talked about, day-to-day functioning,
Okay.
as well as mood and behavior. But they were approved only for their cognitive effects, even though
see.
they may have some of those other ones.
Okay.
There are two groups of these medicines. The first group attacks or really increases a chemical in the brain called acetylcholine.
Acetylcholine. Okay.
Acetylcholine. Acetylcholine is a neurotransmitter in the brain that plummets with Alzheimer's disease. It goes down with normal aging too, but it plummets with Alzheimer's disease.
Okay.
And when we don't have enough acetylcholine in the brain, we can't think and learn and remember as well.
Sure.
And in fact, if you take Benadryl ever for allergies, or even Tylenol PM that has Benadryl in it for sleep,
Yep.
you're blocking acetylcholine transmission in the brain. You're creating confusion as a side effect of the Benadryl. What these medications do is they boost acetylcholine in the brain.
Okay.
And they boost it by blocking a chemical, an enzyme that breaks it down.
Okay.
So there are 4 that have been approved by the FDA. One is no longer used, called Tacrin or Cognex. That was the first one. That was 25 years ago, 1993.
I remember, yeah.
You remember that one?
Yes.
I was in my residency when that thing came out. 3 years after that, the one that everyone's heard about came out, which was donepezil or Aricept.
Yeah.
The reason why Aricept became the most widely used, and still is to this day, is because unlike Tacrin, which was 4 times a day, this was once a day.
Yep.
You took it in the morning with food. Instead of, and there were no problems with liver function abnormalities, which Tacrin caused.
Yep.
And the main problem with Aricept and its cousins, the other 2, ribostigmine or Exelon and galantamine or Razidine, those are the 3 that we use today, they can irritate the GI system.
Sure.
They can cause nausea, in some cases vomiting, and in some cases loose stools.
Okay.
A less common but concerning side effect that we also watch out for is a reduction in heart rate.
Okay.
Some of these medicines can do that as well.
Sure.
But I have to say, for the most part, other than the stomach-related symptoms, they're remarkably well tolerated. The question I always get from families is, what should I expect? And I don't think we in the medical profession do a good enough job about discussing expectations from day one. You should not expect your brain to function like it did when you were in your 40s.
We get that question too, yeah.
Right? But what it will do, compared to being on placebo for the same amount of time, is that the decline in memory, although it will still occur, will be much more gradual.
Gotcha.
The slope of the decline, instead of being like this,
Right.
will be more like this.
Okay.
The question is, how long will that go on for?
Correct.
The studies, for the most part, were 6 months in duration.
Okay.
So we know for 6 months there's a difference. It's not ethical to continue a placebo-controlled study beyond that when we know these drugs have some effect. And so we don't really know for sure. But from our own clinical experience now for 20 plus years of using these medicines, when people have been on them for a while and they're gradually getting worse, but they're relatively stable, and you stop the medicine, there's often an abrupt decline.
Wow, okay.
So my perspective with these medicines are, if there's function in your daily life that's worth preserving, whether it's feeding yourself and walking to the bathroom or something even more than that, then it's worth continuing. Okay. The second class of medication that's on the market is a drug called memantine or Namenda. That medication alters the chemistry of a brain chemical called glutamate.
Okay.
Too much glutamate is toxic to brain cells.
Sure.
So this medication modulates the glutamate transmission in the brain. Nowadays, the standard of care remains a combination of a medicine like donepezil or Aricept with a medicine like memantine or Namenda in combination, because the 2 together seem to work better than one alone. What I will say is that the last medication approved by the FDA in the United States for Alzheimer's disease was indeed memantine, and that was 15 years ago.
Right.
And that really is not acceptable. And that'll get us into talking later about where we're going with treatment.
Research. So I'm sure that, our audience may be questioning is, how can I prevent this disease from developing?
Yeah.
Is there such a thing? So do we start, is there a special diet? Are there supplements? Is there exercises that we should be doing at age 40, 50, whatever age that you guys have noticed?
Yep. So it's a great question. Everyone wants to know, how can I preserve my brain function as I get older? And some people call it healthy brain aging. Yeah. Some people call it successful aging. Regardless, there's a lot that you can do. And the data is variable depending on the major categories that I'll talk about. The 3 major areas that I think about are nutrition, exercise, as well as social engagement.
Okay.
And those are really important. So in terms of nutrition, the diet or the approach to nutrition that most people talk about are all the foods that make up the Mediterranean diet.
Okay.
So the Mediterranean diet, which has been studied for years to help prevent heart disease and stroke, also seems to help with cognitive functioning. Whether it actually reduces the onset or delays the onset of dementia, we don't know for sure. Okay. But if you read all the studies, that's the one that really pops out. So the kinds of the features of that diet are that you are taking nutrients that have anti-inflammatory properties.
Okay.
And so you have a lot of leafy green vegetables. You take foods that are high in omega-3 fatty acids like fish.
Okay.
And you try to avoid a lot of red meat and certain types of fats.
Okay.
So that diet, which is widely used in Greece, in Italy, in the Mediterranean,
Sure.
does seem to have some protective effects. The second is exercise. Of all the studies on prevention that I've seen, the ones on exercise to me are the most amazing and promising. The problem is we can't prescribe nutrition and we can't prescribe exercise. It's all about behavior change, and that's easier said than done. So the exercise data has been demonstrated in both animal studies as well as in human studies. And they've basically shown that exercise not only reduces amyloid plaque and inflammation in the brain, but it does seem to improve memory even in people who already have cognitive problems. So I recommend in my patients all the time, I ask them, what do you do every day to keep yourself physically active? And it doesn't have to be training for a marathon.
Sure.
It could be 30 minutes of aerobic exercise 3 times a week, which involves brisk walking, getting your heart rate to 70 or 80% of what it should be maximum.
Sure.
Strength training and flexibility training. So nutrition, exercise, and then social engagement. This is critical. When people retire and withdraw from the environment at work, there's a huge loss of social engagement, especially, by the way, for the older generation. This is more men than women. Okay. Women have than men at staying connected to other people, just by stereotype.
Sure.
And so social engagement is critical. And we do see that loneliness and social isolation are independently associated with risk for dementia. So trying to stay engaged socially is important. And then I do think it's also, and I didn't mention this one maybe as the fourth category, keeping your brain active.
Yep.
So, and it's not the same routine over and over again. It's something new and challenging. So everyone says, well, I can't do crossword puzzles because it's too hard. Well, you want to challenge your brain, but you don't want to challenge it too much or too little, and you want to do something different. Yeah. And there are now, this is $1 billion industry of brain games, if you want to talk about that.
That's the next, that was the next question. Go ahead. My brain,
well, so brain games, right? So there's a lot of brain games out there on the market. There are a bunch on the internet. I can't say that I would support any one of them, and the reason for that is that the data behind their effectiveness in improving cognitive functioning is it's all over the place.
Okay.
Some are well studied, better studied than others. I will say that Lumosity's done a wonderful marketing job, and they've sort of cornered the market on brain games. Okay. They have a great app. I've had patients who love doing it, feel better, and see their performance improving over time. What we don't know, the real challenge, and Posit Science may be another group that's done a lot of work in this area that's quite reputable, is how does what you're doing on a brain game in terms of performance actually translate to your daily life? Okay. So if you start doing better on these games on your phone,
sure,
does that help you pay your bills better or drive better or remember better in your daily life? And that's what we really have not demonstrated effectively.
So let's go into the research aspect.
Yep.
I know you're a great researcher as well.
Yeah.
So can you discuss that for our audience and how they can be connected with your office and and your researchers on Alzheimer's specifically?
Yeah. So let me put this in the big picture context first.
Okay.
Starting about 5 years ago, the country woke up to the fact that Alzheimer's disease is quickly becoming the epidemic of our times. I would say we have the opiate crisis in this country, and we have the Alzheimer's crisis in this country. Okay. And the opiate crisis, for good reason, is getting a lot of attention today. Sure. What we didn't talk about when we started listing the number of Americans affected by this illness is the cost. In today's dollars, we spend as a country $277 billion on taking care of people with Alzheimer's disease.
I'm sorry, what was that number?
$277 billion.
Wow. Okay.
And a fraction of that is medicine.
Sure.
But a lot of that is care.
Yeah.
Excuse me, including care in the home environment or in the long-term care environment. That number alone is expected to triple as well to well over $1 trillion by the time we hit 2050. And we cannot sustain that financially in this country. Okay. So today in 2018, we're spending $277 billion on care. Guess how much money we're spending on federally funded research for Alzheimer's disease?
I'm sure not even close to that.
$1.6 billion,
yeah.
Which is sort of a tragedy, but that represents a tripling of the NIH budget in the last 5 years.
Wow.
So we're making up grounds, and because of the Alzheimer's Act that was passed during the Obama administration, there's actually a requirement every year to continue to increase Alzheimer's funding. Okay. So, if this year's proposed budget is signed into law, in 2019, the budget for Alzheimer's research at the NIA, the National Institute of Aging, will be about $2.1 or $2.2 billion. Again, effectively nearly fourfold increase over the last 5-6 years. So we're headed in the right direction.
Sure.
But it's a fraction of what we're doing. Most of the money is being spent by the pharmaceutical industry.
Okay.
The best research that happens is when you take academic folks who have been studying this in the lab with new ideas and connecting them with the folks from industry who can then partner together to produce new treatments. Okay. And a lot more of that's going on. And I have to give a lot of credit to the Alzheimer's Association.
Sure.
The Alzheimer's Association, which is the largest non-for-profit charitable organization in this country, not only supports families who are caring for individuals with dementia, but they also help to drive the research forward by investing heavily in research. So the research that is going on right now is trying to get treatments to attack the underlying disease in the brain, those amyloid plaques and tau tangles, before the symptoms are significant enough to affect your daily life.
Okay.
So the challenge is finding enough people.
Okay.
We have the need for about 55,000 research participants in this country to do all the studies that are out there.
Okay.
So the problem isn't that we don't have the studies. Right now, the biggest problem, and why I'm so glad to be doing something like this, is finding people to participate in research.
Okay.
And here's why you might want to participate in research. If you've got a memory problem that's then diagnosed as Alzheimer's disease or mild cognitive impairment, and you qualify for one of these studies, first of all, you'll have testing that you can't get through your regular doctor. Okay. We can actually visualize today the amyloid in your brain using a PET scan, which allows us to see the amyloid light up in the brain under a brain imaging device called a PET scan. Okay. Same thing with these tau tangles. There are amyloid scans you can get by paying out of pocket, but they're extraordinarily expensive. Okay. So you can get information about what's going on with you that you couldn't get otherwise. Okay. If you qualify then, based on the criteria, and you enroll in one of the trials that reduce amyloid in the brain or reduce tau in the brain or prevent them from building up in the first place, you qualify basically for coming into a study site like McLean Hospital or many other places around here. Yeah. And meeting with a researcher, a clinician, investigative team every month for a year and a half. There's a lot of support involved, a tremendous amount of support involved. Okay. We get to know our patients and their families as well as anyone I've ever known in my entire career in my clinical practice, and they're extraordinarily appreciative. So I'll give you an example of a study that's going on right now.
Sure.
There's a drug called aducanumab. Okay. It's an antibody. Okay. We inject it through the vein, it goes up into the brain, it binds to the amyloid in the brain, and it causes it to go away. It basically causes an inflammatory reaction, and the amyloid dissolves. Okay. That's the theory. The original study that Biogen, based here in Cambridge, did a couple years ago showed that even in a smaller than a 200 patient sample, that if you give people this drug over the course of a year, not only does the amyloid go out of the brain, so you can see this, it disappears from the brain scan, but cognitive performance also improves. Wow. And the higher the dose, the better people did. Okay. So they invested mightily in this compound. And they're now conducting 2 identical phase 3, which is the final phase before potential drug development, with over 3,000 people around the world. And we're involved in this here at McLean and elsewhere in the Boston area. If this medication, and people come in to see us once a month for 18 months, and once they're done with 18 months of drug or placebo, they definitely go on drug. Okay. So again, even if you wind up on placebo for a year and a half, you then can stay on drug for up to another 5 years at least afterwards. Okay. About a year from now, this fall, maybe a year from this fall, we're going to know what the probable results are from this study. It could potentially be the first disease-modifying therapy for Alzheimer's disease. That's so instead of the medicines on the market now that help symptoms for a while, it could actually eradicate the underlying disease and keep people stable for much longer.
That's incredible.
That's the theory, at least. So there are many of these trials going on right now. One thing we've learned from research is that if you intervene with these treatments that reduce amyloid and reduce tau, if you intervene with them too late in the game, when someone can't drive or pay their bills, they don't work.
I see.
We've had more than a dozen failed trials over the past 5, 6, 7 years. But the earlier we start, the more likely it is to work. And there are signals now from earlier research that, in fact, if you start early, that's when you can halt the disease in its tracks.
Thank you so much. And we will have information on your research and how individuals, our viewers, can reach out if they're interested in the credits. So thank you so much, Dr. Forrester.
Thank you.
Dr. Forster, I want to thank you again for taking the time to be with us today and to share your expertise on this, this disease that, if I may call it a disease, you described it as being just like the opioid crisis. And I hope that more research will be done to hopefully one day eradicate this disease that has afflicted millions and millions of people.
If I may mention one other aspect of the illness, because you alluded to it in the beginning, if we do have time.
Please.
So you mentioned that the behavioral symptoms of dementia are often the most troubling for families.
Yes.
And when I talk about behavioral symptoms, I'm talking about anxiety and agitation and depression and hearing things and paranoia. These are symptoms that occur as the disease progresses.
Okay.
And although memory loss is devastating to families and patients, as well as reduction in functioning, it's these behavioral symptoms that really drive the burden of the disease. Yeah. This is why caregivers often themselves get physically sick and emotionally worn out and depressed themselves. This is why individuals with Alzheimer's disease wind up not being able to live at home anymore. The good news is we can treat these problems. There are medicines not approved by the FDA that help reduce these behavioral symptoms of anxiety, agitation, irritability, aggression, and depression, and can help dramatically improve quality of life for patients and caregivers. So when I think of dementia, the hope is not only in curing, but we still have to treat people who will have this disease, and focusing on the behavioral symptoms will be so important.
Thank you so much.
Thank you for letting me say that.
My pleasure. Thank you so much. Hopefully, as more advances are made in Alzheimer's research, and yet more diagnoses are made each year, the diseases that afflicts many Americans, hopefully will go away. That's our hope. And I want to thank you from the bottom of my heart for taking the time. I know how busy you are, for being here with us and sharing your expertise on the disease of Alzheimer's. And like I said, we will have some at the end of the show, in the credits, some information how people can reach out to you and your staff.
Great. Thank you so much.
Thank you so much.
Appreciate it.
Thank you.
Take care.
Thank you all for tuning in to Healthier You. I'm Saad Dinno, co-owner of Acton Pharmacy, Keys Drug and Newton, and West Concord Pharmacy. I look forward to seeing you around town. Be well.